heart valve, the concern would be that we have to consider the pre-medication. So you have a patient with a prosthetic heart valve, then we say, okay, this patient is going to need pre-medication. Let's see the list of medication patient is under. So patient is taking metformin. That probably says that patient may have diabetes. So that's something that we have to ask the patient later if the patient has diabetes and if it's under control, or we will have to ask for the HbA1c. The third medication the fourth medication that we have here is warfarin. So if the patient is coming for extraction, my concern with warfarin is the bleeding. So what I need to have is the INR prior to the extraction. I have to make sure the INR is below 3.5. So if I see here the current findings, I don't have the blood glucose. Every time patient comes to the clinic, you have to take the blood glucose. We don't have it. It seems the other vital signs are stable. And we have a spontaneous gingival bleeding and an INR of 5. INR of 5 is very, very high. And maybe that's the reason of the spontaneous bleeding, right? Okay, Carrie, let's go with the question, please.
Which mechanism of action most likely explains the current complaint? A, vitamin A inhibition, B, direct thrombin inhibition, C, antithrombin 3 activation, D, platelet aggregation inhibition.
So we know the warfarin is vitamin K inhibition, right? So here the correct answer is vitamin K. But even you know that vitamin K the warfarin is inhibit the vitamin K, I want you go through all the options of the question, take the time to analyze each one of them before going directly to the correct answer that you think. Sometimes in this case, there's no doubt, but there's another type of question that you have to analyze a little more the other options to see which one is the most complete. But this one, definitely vitamin K inhibition is the mechanism of action of the warfarin. You can have a platelet aggregation inhibition. You have the other ones, right? Like aspirin, Plavix. You can have the direct thrombin inhibition that you have with we'll see later in the next slides.
So the answer from this question should be drawn from the readings on the first part of the semester. Is that what we're talking about? So the answer to this question should be found in the readings of the early in the semester, or is there a lecture that directly addressed this one?
Basically, is for the first semester, right? You have to. We have been mentioning the warfarin many times, right? So then you need to know what's the mechanism of action of warfarin, how is it going to affect it. But in case you don't know, it's okay. You can, everyone can go to the Google now and type warfarin mechanism of action. And what you find. So, for example, this question is, it's allowed, you can go to Google in case you don't know what's the warfarin, right? And so then you can go to Google and then you're going to say, oh, vitamin K inhibitor, and then that's the answer. And it's okay. This is, if in the clinical setting, if you don't know anything, then just go to Google, review it, and make sure that, and find the answer. You have to have that prior to plan the treatment of your patient. You have to have what it means prior to present the case to the faculty. So don't go to the faculty and say, oh, patient has this, and then boom, I don't know what they are. Okay, let's go to the second question. Okay, let's go to the second question. Ritika? Oh, no, I'm sorry. Michelle? Can you read the second question for us, please?
So the patient is a female, 12 years old. Her chief complaint is my mouth hurts. Her background and or patient history is that she had her 4 first premolars extracted 24 hours ago, and current findings include no swellings.
Okay, it's a straightforward case, right? So can you read the question for us?
Post-treatment discomfort is best managed with A, acetaminophen, B, codeine, C, ibuprofen, and D, tramadol.
So basically, this question, because it's extraction, they assume that you have a pain, they assume that you have a inflammation, and that's the reason why will be the best answer here, that cover pain and inflammation. Inflammation doesn't mean swelling, the huge swelling, right? Inflammation can be something local, that you disrupt the tissue, they can have a little inflammation, and so will be the best answer here. For a patient who doesn't have any medical history of healthy, and then it's a simple extraction, and then you're not going to give opiate medication like codeine or tramadol, right? So your option is between Tylenol or ibuprofen. But the Tylenol, it doesn't cover the inflammation, so that's the reason why ibuprofen is the best answer here. Okay, let's go to Erin. Would you like to read the next one?
Sure.
Thank you.
The patient is a male, 65 years old, with a chief complaint, my tooth has turned dark gray. He has a prosthetic heart valve and is taking warfarin, and current findings is that tooth number 24 is necrotic, not responding to cold, no swelling present, and he has an INR of 3.
So what's your concern, this patient?
Pre-medication for his prosthetic heart valve.
When you give pre-medication, what's the pre-medication that you have to give if the patient doesn't have allergies to penicillin?
Is it 200 milligrams of amoxicillin?
Okay, amoxicillin 2 grams. Amoxicillin 2 grams. When you say pre-medication, you have to say what type of medication, the doses, and you have to, basically the dosage, right? So you have to say amoxicillin 2 grams, 30 minutes to 60 minutes before the extraction. So every time when someone asks you for pre-medication, then you have to say amoxicillin 2 grams, 30 minutes to 60 minutes before the extraction. If you say amoxicillin, that doesn't say anything, because you can say 500 milligrams, 100 milligrams, and those are not the correct dosage for the pre-medication. Okay, what would be the alternative for the penicillin in case someone has allergy to penicillin? So the alternative is the clindamycin 600 milligrams, 30 minutes to 60 minutes before the procedure. Okay, so you have 2 types of pre-med, possible pre-med. You have other possibility too, but these are the most common one. So you have amoxicillin 2 grams that you have to take 30 minutes to 60 minutes before the extraction, or you can have a clindamycin 600 milligrams, 30 minutes to 60 minutes before the extraction. So this is the pre-medication, okay? What the other concern with this case?
Bleeding? Bleeding.
The bleeding, perfect, because patient is taking warfarin. So every time patient is taking warfarin, what's the first thing that has to come to your mind that you need?
INR.
The INR, PT, INR. So someone asked me when you ask for the PT, when you ask for the INR. So PT, the prothrombin time is the one that you need in order to calculate for the INR. You don't have to calculate anything because the lab sent that to you. But the INR basically is the international normalized ratio of the PT, of the prothrombin time. That's the reason why that test is PT INR. Okay, there are no different tests. So that's what you need. You need the INR. And what's the INR that allows you to take the tooth out?
3.5 or lower.
Below 3.5. That's very important. Below 3.5. And this patient has an INR of 3, so we should be able to do the procedure, right? So let's go to the question. Would you like to read the question, please?
Before extracting tooth number 24, which one of the following is the best option? A, no antibiotic administration is required. B, amoxicillin 2 grams should be taken 30 to 60 minutes before procedure.
So this one, so the first one, the A, you rule out immediately because you already knew the answer before, right? So you need to give the pre-med. So the second answer is B, amoxicillin 2 grams should be taken 30 minutes to 60 minutes before. You say, yes, this one should be the one because you already knew before. Okay, let's go to the next one.
C, warfarin should be discontinued the morning before the procedure.
No, we never discontinue any medication unless this is a physician recommendation. We don't do that. We have to, unless you have any question, then you have to ask the physician, but we don't do that by ourselves. So we don't discontinue ever any type of medication without the physician recommendation. Okay, so this C we rule out. Let's go to D.
Clindamycin 150 milligrams should be taken 30 to 60 minutes before procedure.
So you knew before that clindamycin could be another option, right? But then you knew that you need 600 milligrams. And here it says 150 milligrams. So this is an incorrect answer. So now the answer that you have, which is the best, is B. Okay, great job, thank you. Do you have any question here? I don't see anything in the chat, so let's go to the next one. Okay, so we have another question. Let's go to Jake. Can you read the question for us, please? The case. Okay, I don't know, Jake maybe is not here. Brad, can you read the case for us, please? Okay, we don't have Kelsey.
Okay. Chief complaint is my mouth has been dry for over a month. Background or patient history, there's previous endocarditis, medications, warfarin, and current findings are tooth number 24 is missing, incisal 1/3, and the INR is 3.
So according to the medical history of the patient, what would be your concern if the patient is coming for extraction?
Like bleeding because it's taking warfarin.
Okay, what other thing would be your concern?
The endocarditis.
Yeah, when the patient has a history of endocarditis, we have to give the pre-med, right? And what the pre-med that you think that you should give this to this patient?
Probably amoxicillin 2 grams.
Okay, amoxicillin 2 grams, 15 minutes before, 4 hours before, 12 hours before, how long? You have to give like the instruction to your patient, right? So you want to you tell the patient you have to take the amoxicillin 2 grams. Mm-hmm. One.
Probably 30 minutes, maybe.
Yeah, 30 minutes to 60 minutes before the extraction.
Okay.
Right? So what would be the alternative of penicillin in case the patient has allergies to penicillin?
Clindamycin.
Okay. So every time when someone asks you for pre-medication, make sure that you say amoxicillin, 2 grams, 30 minutes to 60 minutes before the extraction. And the alternative would be clindamycin, 600 milligrams, 30 minutes to 60 minutes before the procedure. If someone asks you for pre-med and you say only, oh, amoxicillin or clindamycin, you're not saying what's the pre-medication, okay? So every time when someone asks you what pre-medication you're going to give the patient, you have to make sure that you say amoxicillin 2 grams, 30 minutes to 60 minutes before the procedure, or clindamycin 600 milligrams, 30 minutes to 60 minutes before the procedure. Okay, those are the two things. Very good. So you have a concern with the warfarin, and what will be the warfarin that the INR that allow you to work in this patient, that allow you to extract the tooth?
Less than 3.5.
Less than 3.5. Great. Okay, let's go to the question.
Before A, no antibiotic administration is required. B, amoxicillin 2 grams should be taken 30 minutes to 60 minutes before the procedure. C, warfarin should be discontinued the morning before the procedure.
No, we already discussed that we don't discontinue anything.
Yeah. And then D, clarithromycin, 500 milligrams should be taken 30 minutes to 60 minutes before the procedure.
Yeah, no. So definitely, probably I'm not going to do the clarithromycin, but because probably, you have had this before in your previous pharmacology class, the type of medication that is clarithromycin, but I'm not going to go to that. So probably I will add something. If I have to do a question like this, I will give you some other data that is probably easier for you to have in your mind. I understand when you don't use something very frequently, you're not going to remember. So I won't do that. This type of option. So now you know definitely the correct answer is B, right? Amoxicillin 2 grams. 30 minutes to 60 minutes before the procedure. Okay, let's go to the next question. Jelani, can you read the question for us, please?
Hello, can you hear me?
Yeah.
Yeah.
Let me see. Hello, yes, can you hear me?
No problem.
Okay, which mechanism of
No,
action
read the
most
case.
likely
Can you read
explains
the
the
case?
chief complaint?
Can you read the case, not the
Do you want
question?
me to read I go through the patient. A male, 60 years old, my gums bleed easily. Background and or patient history. Okay, paroxysmal supraventricular tachycardia, pulmonary embolism, type 2 diabetes, hypertension, hyperlipidemia, medications, metformin, atorvastatin, warfarin, aspirin, 81 milligrams daily. Current findings: blood pressure 145/90, diffuse gingival bleeding.
Okay, so what would be your concern here?
You want me to read the answers again?
What would be your concern when you see this medical history of the patient? What would be the major thing that you say, okay, you have to keep in your mind before you treat the patient?
Sorry, I can't hear you.
So basically, there's a lot of, in the clinic, you're going to encounter patients with lots of medical history, very long. So you have to make sure that you try to group them, and then you have an idea of how you're going to approach that case. For example, this patient has supraventricular tachycardia, the patient have hypertension. That means the patient have a cardiac issue. So first thing, when you have a patient with cardiac issue, we discuss about we discussed about the epinephrine, right? 0.04 milligram of epinephrine as a maximum. So then you say, okay, if the patient is stable from the cardiac standpoint, I can treat the patient, but then I have to be careful with the administration of the epinephrine. So then the second thing is patient have diabetes. So we have to see if they're under control or not. And remember that we discussed that all the time we have to check the blood glucose. If a patient of our record has been coming here all the time and all the blood glucose has been under control, then we're not going to request any HbA1c. But it's a patient, if the patient is coming here and the blood glucose is out of control, is like 250, and we don't have any history of the patient, and the patient doesn't have any emergency, we will ask for an HbA1c. So we will ask for a med consult. The other concern here is the warfarin. Patient has pulmonary embolism. That means the more clotting problem. So in this case, say pulmonary embolism, that probably sometimes we can put like a deep venous thrombosis, DVT, and has as a medication warfarin, right? So the major concern here is the warfarin. So the warfarin is the possibility of bleeding. So, and we have to make sure that the INR is below 3.5 before we can treat the patient. If we don't have the INR of the day, we will have to ask for an INR 24 hours prior to the surgery, right? So those are the things that we have to, those are the things concern that we have to keep in our mind before we treat the patient. Okay, let's see with the, so this mechanism of action of the warfarin basically, right? We already discussed that before, that warfarin inhibit vitamin K. So the correct answer here is vitamin K antagonism. Okay, let's go to this next one. Anna, can you read this case for us, please?
Female, 59 years old, with a chief complaint of I have many missing teeth and several more are loose. My mouth is also dry. The background is that she has hypertension. The medication she's on is aspirin, 81 milligrams, and hydrochlorothiazide and trimeterine. She works in the shoe section of a department store. Her current findings is that she's 5'9" and weighs 140 pounds. Her blood pressure is 123/78. New patient presents for an initial examination, missing many teeth. Several remaining teeth exhibit class 1 and 2 mobility. She wants to save as many teeth as possible, willing to consider upper and lower partial dentures. Intraoral examination reveals profound mucosal dryness. Manipulation of major salivary gland ducts fails to produce saliva.
Okay. So if this patient is coming for extraction, we see the medical condition, the major concern is hypertension. If we have to do perform an extraction, we have to think about the 0.04 milligram of epinephrine as a maximum. And beside that, patient seems okay, right? Okay, let's go with the question.
Each of the following is an appropriate patient management measure except one, which is the exception. A, antibiotic premedication prior to surgical procedures. B, respect for patient's autonomy. C, referral to a dental specialist. And D, use of local anesthetic with epinephrine.
Well, actually, you're not going to have this type of question, right? But so antibiotic prior to the surgery, patient doesn't have any medical condition that need treatment, right? So definitely not. And respect for patients' autonomy, manipulation. I'm not so sure. Okay, let's go stand by that one. Refer to a specialist. I mean, if this type of patient is coming for multiple teeth extractions and the teeth is not in good shape, that is not possible to be saved, then definitely you guys can do the extraction. You don't have to refer the patient unless it's wisdom teeth or something like that. Use of a local anesthetic with the epinephrine. Yeah, patient has hypertension, so you can use epinephrine, but you can use a maximum of 0.04 milligram. Yeah, so I don't know what will be the we won't have this question. Okay, I don't know so far, do you have any, I don't want you to think that this is all the question that you're going to have an exam, okay? We're going to adjust the question to what we have in the, during the semester with the material that we have had during the semester, but the way how I want you to approach the cases is first read the case, idea what type of consideration you have to have for the patient before going to the question, and having that in the mind, and then answer the questions after that. I don't want you to go directly to the question, not analyzing first the patient. I don't know, do you have any question? I have a few questions of the Tuesday session, basically how to approach the lecture of the implant lecture. So I'm going to send you a guide, what type of thing you have to, it's very important to have that in your mind, learn that before you, before the day of the exam. And I will upload to you the epinephrine, what it means, the epinephrine when it's 1 to 100,000 K and 1,000 epinephrine, 1 to 15,000, things like that.
How many questions are on the exam?
We're still working on that, the number of questions, because the idea is to allow you to have enough time to answer each question, because you cannot go back to that question. So that allows you to analyze the question and answer it within 1 hour. So we're still working on that.
Dr. Sun, when you say that's going to lock and not let us go forward, will we at least see the case and then the 2 or 3 questions that are associated with that case on the same
You're going to have the case. You're going to have the case for each question, so you don't have to go back to any case. The case is going to be like this, next to your question.
Okay.
Yes.
Thank you.
Oh, you're welcome. So we have a few questions about the ASA 3 or ASA 4. I will send you a brief summarize, so you can have a very better definition. One is 2, one is 3, one is 4. But we keep that in the mind that sometimes we have a grayish area between 3 or 4, 2 to 3, right? So I will avoid having that type of question to make you, because if the patient is in that grayish side of range, so it could be 3 or could be 4. So if I ask you a question like that, and then I put those 2 options, then I should consider both options as a correct answer. So we will avoid that. But if the patient is a 4, and then you answer 2 or you answer 1, definitely you have the wrong answer, right? So keep that in your mind, that you're not going to have those grayish type of question. And if you have that, I will have to amend it. Any other question?
Yeah, actually, I have a question. So I went over the implant lecture, and I could not understand what platform shifting meant.
Okay, so that's not the thing that I'm going to, for the implant question, I'm going to give you a guide of what type of thing I want you to understand. Because what we want you to understand is basically the surgical standpoint. And you're going to have a 3 years, the implant portion of the prosthetic part, and then they're going to give you more information. So in that class, Dr. Jin added more of those informations for you to have that. But then I'm going to emphasize a few of the important things I want you to have in your mind when you start planning implant for your patient next year.
Okay, thank you.
Oh, you're welcome. Any other question? So the exam is cumulative, right? So you're going to have all the lecture that we have before and the lecture that we have after the COVID-19. Those are the PDAs. That the other one I put only the essential that you need to know. So you just have to read a book and learn it as a book system. Mm-hmm. One thing is for the lecture of the analgesia, it's very similar what we have been doing now. So you have a patient with kidney disease or you have a patient with liver disease, you have to consider what type of medication you have to give those patients after the extraction, right? You have to make sure that if the patient have a kidney disease, that medication that you're going to give the patient is not affect more the kidney of the patient. Or the medication that patient have a liver disease, you have to consider what's the liver, the stage of the liver disease, and you have to do some type of doses adjustment of your medication. And actually, in the lecture, I put like a table to guide you and have an idea what type of medication you can give to each patient when they have a cardiac issue, liver disease, or kidney disease. Any other question? Okay. Thank you very much, everyone, and thank you very much for your patience. It took me a little longer to start this. So if you have any question, you can send me the question, and if you feel that you need a little more reinforcement of that, maybe you can contact Sarah, and then maybe we can do extra session the next week. Okay, have a nice day. Thank you.
Thank you.
Bye.